In our last sketch, we covered what happens when gallstones form and roll around the biliary system. For round two, we'll take a look at two acute, inflammatory, and oftentimes infectious complications of gallstone disease: acute cholecystitis and acute cholangitis, which is why we find ourselves at this eerily eyes wide shut sort of bocce court. A masquerade themed game complete with costumes, fountains, and a bubble tea bar. First, some rules of the game. The word cholecystitis simply means inflammation of the gallbladder, which most commonly occurs as a result of cystic duct obstruction by a gallstone. Which is why this bocce ball stone has pulled down the gallbladder green tablecloth, inflaming it along the way, if you will. This flame is the key difference between acute cholecystitis and symptomatic cholelithiasis. Whereas both conditions are caused by stones blocking the cystic duct, the prolonged obstruction in acute cholecystitis leads to acute inflammation and all the consequences that come along with it. And speaking of, right upper quadrant pain is characteristic of acute cholecystitis and tends to be more severe and more prolonged than that caused by biliary colic. Sort of the same way being stabbed in the side with a fork is gonna hurt a little more than a tight dog leash. Poor guy. As with biliary colic, acute cholecystitis can be precipitated by a fatty meal. How appropriate then that rich Italian fettuccine was on the menu tonight. Also, as with biliary colic, patients with acute cholecystitis may present with nausea and vomiting, hence the sickly green mask. Unlike biliary colic, however, patients with acute cholecystitis often present with fever, which should tip you off that there's more going on than symptomatic cholelithiasis. To help you remember the fever associated with acute cholecystitis, we've added a flaming headpiece to our party patron here. While most cases are a consequence of gallstone disease, some cases of acute cholecystitis may occur without the presence of gallstones. This is referred to as a calculus cholecystitis. Go figure. Which typically occurs in patients who are already critically ill from something else. Common causes are recent massive surgery, severe trauma, extensive burns, sepsis, or pretty much anything else that can lead to gallbladder stasis and ischemia. This gallbladder stasis and ischemia are the impetus for inflammation. So we've sketched in this ill-appearing, unconscious guy who's not moving, and seems to have started a fire on this gallbladder tablecloth. No stones necessary. Moving on. Always take into account fever seen on initial vital signs, as this is a key feature suggesting acute cholecystitis rather than biliary colic. As you'd expect, patients with acute cholecystitis often have tenderness to palpation in the right upper quadrant due to local irritation. Additionally, they may also have rebound tenderness or guarding due to parietal peritoneal inflammation. Hence this guy falling backwards in his chair from that bocce ball rebounding in his face, clutching his right upper quadrant as he guards for impact. The flame pattern on his shirt is there to remind you that peritoneal inflammation is what causes the peritoneal signs of rebound tenderness and guarding. One physical exam finding you'll absolutely come across on wards and exams is Murphy's sign, which is pathognomonic for acute cholecystitis. To elicit a Murphy sign, have the patient maximally exhale and apply pressure under the costal margin in the area of the gallbladder. Have them slowly inspire, which forces the gallbladder down towards your awaiting hand. If the gallbladder is acutely inflamed, they will quickly stop inhaling and may even shriek a bit as the inflamed peritoneum comes into contact with your hand, or an ultrasound probe for that matter. To help you remember the Murphy sign, we've sketched this woman suddenly taken aback in pain as his hand is, applied to her side. In many cases, the sign elicited on ultrasound is more accurate as the probe provides a better tool for getting under the costal margin, and since it's performed under visualization, you'll know for sure it's the gallbladder that's irritated. So, physical exam or imaging finding? Little bit of both. Alrighty, this room's getting a little dark a lot of fast. The ominous looking masks here are to remind you of white birds, and more specifically, the elevated white blood cell count you'll often see with acute cholecystitis. Other lab abnormalities, such as elevations in bilirubin, alk-Phos, or GGT, like cholangitis or choledocholithiasis, which fits into the sketchy mantra. The more serious it seems, the less likely it is to just be the gallbladder. Remember that. So you have what you suspect to be acute cholecystitis. How do you clench the diagnosis and score? As it is with many hepatobiliary conditions, abdominal ultrasound should be the first imaging performed for suspected cholecystitis, which is why we can't have a bocce match without an ultrasound bullhorn. On ultrasound, gallbladder wall thickening is highly suggestive of cholecystitis, especially if the gallbladder wall is more than 4 millimeters thick. Inflammation can also lead to small fluid collections surrounding the gallbladder, known as pericholecystic fluid. To help you remember gallbladder wall thickening on ultrasound, this bullhorn has an extra thick rim. Another thing to be on the lookout for is gas within the gallbladder wall and, to a lesser extent, within the lumen. This is referred to as emphysematous cholecystitis, and it tells you that just got real, as the likelihood of gangrene and perforation is instantly higher. But more on that later. For now, just remember that the bubble T within the wall, i.e. on the ledge, may be seen on gallbladder imaging. If the diagnosis of cholecystitis isn't completely confirmed by ultrasound, an additional imaging modality available is colescintigraphy, aka hide-a-scan, which is why this guy is hiding a stolen clutch of sorts under his coat. Hide-a-scanning involves IV injection of a radiotracer that's excreted by the liver into the bile. Therefore, following injection, you should expect to see it make its way out of the liver, through the common hepatic duct, into the gallbladder, down through the common bile duct, and finally, out into the duodenum. If cholecystitis is present, meaning the cystic duct is obstructed, the gallbladder won't fill with contrast while the rest of the biliary system will. Non-visualization of the gallbladder after a certain amount of time is highly suggestive of cholecystitis. To illustrate this concept, notice how the handle of the clutch, representing bile ducts, is glowing radioactive green, while the gallbladder itself, squeezed tightly in his hand, doesn't have the same glimmering glow. Cholecystitis oftentimes doesn't give you too much to work with right off the bat, so it's important to keep in mind other pathologies that can present in the same way. An important part of diagnosing acute cholecystitis is differentiating it from run-of-the-mill biliary colic. The key features indicating acute cholecystitis over biliary colic are fever, leukocytosis, a positive Murphy sign, and gallbladder wall thickening on ultrasound. Choledochal lithiasis may also be present with right upper quadrant pain, but expect to also see jaundice, a cholestatic pattern of lab findings, such as elevated bilirubin, alk-phos, GGT, AST, and ALT, and common bile duct dilation on abdominal ultrasound. Acute pancreatitis should always be on the DDX of abdominal pain, but with acute pancreatitis, expect to see sharp pain radiating to the back and elevations of serum lipase and amylase to over 3 times the upper limit of normal. Acute liver diseases can cause right upper quadrant pain, nausea, and vomiting as well, but with acute liver diseases, expect to see jaundice, hepatomegaly, and a hepatocellular lab pattern, meaning super high AST and ALT, elevated conjugated bilirubin, and modestly elevated alk-phos levels. Let's summarize the classic presentation of acute cholecystitis in a sample assessment statement. Sister Coley is a 43-year-old obese woman presenting with severe right upper quadrant pain for the past 12 hours. She's had similar episodes of pain in the past, but they weren't as severe or prolonged as her current episode. Vitals are significant for a temp of 38.8 degrees Celsius and heart rate of 110. Physical exam is significant for right upper quadrant tenderness and positive Murphy sign. Abdominal ultrasound is significant for thickening of the gallbladder wall and pericholecystic fluid. Labs are significant for a white blood cell count of 15,000 with a left shift. Given her exam, lab results, and imaging findings, the most likely diagnosis is acute cholecystitis. Alright, with your diagnosis of acute cholecystitis in hand, it's time to act. First things first, make patients nil per os, aka NPO, aka non-potable. This helps with nausea and is a good rule of thumb whenever there's any possibility of having to go to the OR. And the IV? IV fluid should be administered as a resuscitative measure, as supportive care is a staple of treating acute cholecystitis. NSAIDs are a good first measure for pain control as long as there's no contraindications, such as peptic ulcer disease or significant renal impairment. But the majority of patients with acute cholecystitis will require parenteral opioids to get pain under control. To help you remember both, recall this NSAID fire extinguisher and Mutopia masquerade sign. While infection isn't always present, bacterial overgrowth due to acute cholecystitis can spread throughout the gallbladder and biliary system, sometimes even resulting in sepsis. This is why empiric antibiotics are given at least until the gallbladder is out. While the regimen may vary, it's important to cover the top 3 pathogens associated with cholecystitis and biliary tree infection: E. coli, Enterococcus, and Klebsiella. While supportive therapy with IV fluid resuscitation, pain control, and antibiotics are crucial, source control is even more crucial. That's why patients who are stable enough for surgery, i.e., not in septic shock, should undergo early cholecystectomy, as within 72 hours of admission. To help you remember early cholecystectomy, check out the rising sun on that surgical papaya hat. Before we move on, let's talk a little about the really bad things that can happen in patients with acute cholecystitis. In severe cases, the inflammation in acute cholecystitis can lead to gallbladder ischemia and necrosis, resulting in gangrene. Gangrenous cholecystitis is the most common complication of cholecystitis and is more common in patients with increased age, diabetes, immunosuppression, or late presentation. To help you remember inflammation, ischemia, gangrene, and perforation, the wall of this gallbladder green tablecloth is charred and torn. Local inflammation and perforation of the gallbladder wall can lead to fistulization with surrounding tissues. And what organ is close to the gallbladder and has a lumen perfect for fistulizing with? The duodenum, of course. While cholecystoenteric fistula formation is usually the consequence of long-standing, slowly developing pressure necrosis secondary to gallstone disease, it can sometimes develop following acute cholecystitis. And a path-obstructed sign on that small intestine-looking mat can only mean one thing: small bowel obstruction. If a large enough gallstone passes through a